Typically, a transseptal puncture is part of a more specific diagnostic or therapeutic procedure. The indications for the procedure are reviewed along with a review of the patient's medical history. Informed consent is obtained. After a focused cardiac and vascular physical examination is performed, equipment for monitoring blood pressure, oxygen saturation, and ECG is placed. Place the patient on the cardiac cath lab table. Prepare and sterilely drape both groins and one or other radial artery access if that site is to be used. Right femoral venous access is obtained using standard technique, and an 8 French sheath is inserted. Arterial access is commonly obtained as well. Place a pigtail catheter in the ascending aorta at the level of the aortic valve to provide fluoroscopic identification of the aorta. The intracardiac echocardiography, or ICE catheter, is advanced to the right atrium, and images of the septum are obtained. The transseptal catheter and dilator are flushed, and the dilator inserted into the transseptal catheter. The Brockenbrow needle is flushed, removing the inner stylet to do so, and is placed inside the transseptal dilator. The needle is advanced to the tip of the dilator, and an assessment is made of the distance still present on the proximal end of the needle, typically using the width of 1 or 2 fingers to assess that distance. This is done to ensure that when the system is in the patient, the needle is not inadvertently advanced outside the dilator. A 0.032-inch J-tipped wire is inserted into the femoral venous sheath and advanced to the superior vena cava. The 8 French sheath is removed, and the transseptal catheter with dilator is inserted and advanced under fluoroscopic guidance into the superior vena cava, curving the catheter so that it points to the patient's left. The wire is removed, and the dilator is aspirated and flushed. A stopcock is placed at the proximal end of the dilator and pressure tubing system placed on the side arm of the stopcock to allow for pressure monitoring during the puncture. A baseline right atrial RA pressure recording is obtained. The Brockenbrow needle has a gentle curve on its tip. Many operators will accentuate this curve a little bit for relatively normal anatomy, with greater degrees of curvature applied if a significantly dilated right atrium is present. The stopcock is removed from the transseptal dilator, and the Brockenbrow needle is inserted. This may be done with or without the included stylet, which may ensure the needle does not catch on the dilator as it is being passed through the dilator. Under fluoroscopic guidance, it is advanced through the dilator until it is 1 to 2 centimeters from the tip of the dilator, taking care not to advance it outside the dilator using fluoroscopy and the previously obtained assessment of the needle measurement. Gentle rotation of the needle should be done while advancing it to ensure the dilator maintains its position pointing to the patient's left side. The stylet is removed when the needle is in position. An RA pressure recording should be present. The entire system is rotated clockwise until the needle or stopcock is approximately at 4 to 5 o'clock. TEE imaging should be done to image the atrial septum. A bicaval view can be useful at this stage. Keeping the X-ray source in an AP view, the transseptal catheter needle system, with the clockwise tension maintained, is pulled downward in a controlled manner. There are typically 2 drops of the catheter, which may be seen and palpated. The first occurs as the catheter drops over the aortic knob, also identified by the pigtail catheter in the aorta, and the second occurs as it falls into the fossa ovalis of the atrial septum. With the slight advancement of the transseptal catheter described above, tenting of the atrial septum should be visible. If this is present and at the desired location, then continuation of the transseptal puncture may ensue. If, however, tenting of the septum is not seen, or it is not in the ideal location, the catheter may be pulled back slightly, 1 centimeter, and rotated slightly, then re-advanced. Typically, it is rotated more posteriorly or given clockwise rotation. Once tenting of the septum has occurred at a desired location, the needle can be advanced across the septum. During this maneuver, it is important that the needle not be allowed to advance too far, which can occur as it pops through the septum. As the catheter is advanced to cause tenting, typically the pressure tracing becomes a flat line, and then a left atrial tracing may be seen as the catheter crosses. Once the dilator is across, it is stabilized with the right hand and the catheter advanced with the left hand. Once the catheter is seen to be across the septum by fluoroscopy and TEE, the dilator and needle can be removed in a controlled manner to minimize inadvertent introduction of air into the catheter and left atrium. The catheter is aspirated and flushed and connected to pressure monitoring. Parenteral heparin is administered, typically sufficient to achieve an activated clotting time, ACT, of at least 200 seconds, with higher numbers preferred by some operators. The catheter may be exchanged over a wire, either a 0.032-inch coiled INUI wire or a 0.035-inch exchange-length J-tip wire, often placed into the left upper pulmonary vein for stability and to avoid inadvertent catheter placement in the left atrial appendage, which can be more thin-walled and easier to perforate. Appropriate transseptal systems can then be delivered to the left atrium for various procedures, including balloon mitral valvotomy and transcatheter mitral valve repair. After the procedure, the transseptal system can simply be pulled back across the atrial septum, although the balloon used for mitral valvuloplasty has a specific removal procedure. If the procedure is being done with echocardiographic guidance, images should be obtained immediately if there is post-procedure hypotension, specifically to look for pericardial fluid. After completing the procedure, the patient is discharged from the cath lab with standard post-catheterization management and monitoring.